consider.
Yes, sir, I am here.
Yeah,
Am I
please,
audible, sir?
please go ahead.
Yes. This is the fluctuating blood pressure and its clinical implications, sir. I'll generally keep myself with the variability of the blood pressure and the cardiovascular risk of it. Sir, we know it doesn't move. Yes, sir. Leading blood pressure is a global burden, sir. Hypertension, as we see, sir, 69% of the first MI are associated with hypertension, 74% of the coronary heart disease, 77% of the first stroke, and 91% of the congestive heart failure are generally associated with hypertension. Then reduction of the blood pressure is so much important. Just 2 mm reduction of the systolic blood pressure reduces the ischemic heart disease by 7% and stroke by 10%. Then again, benefit of the BP control, we can see 10 mm reduction of the systolic blood pressure, 50 to 60% lower risk of stroke, 40 to 50% lower risk of coronary arterial disease, and 50% lower risk of congestive heart failure. Greater benefit with older age. Then this is CSI cardiac prevent trial, which was conducted in 21 states of India, around taking about 2 lakh people. 36% of the general population of Hyderabad were affected. Okay, sir. Then if we consider the blood pressure pattern of our country with the help of 142 meta-analysis, we can see that the prevalence in rural area is around 28%, in the urban area is 34%, awareness in 25% in the rural area, awareness is 42% in the urban area, treatment is 25% in rural and 38% in urban, control is only 10% in the rural and 20% in the urban. Then blood pressure, there are some important things which are actually not so much considered. BP variability is one very important thing, central blood pressure and the aortic stiffness and mast hypertension. Then these are actually some BP reactivity. BP reactivity is a very important phenomenon, sir. When generally our blood pressure responds to the various stressors, suspected to be predictive of future development of hypertension and cardiovascular risk. Studies have not found this to be very much true. Then BP lability. BP lability is another characteristic of the human blood pressure. It is always labile. Blood pressure is generally labile. No clear definition that differentiate normal than abnormal blood pressure lability. Labile hypertension widely used, lacks an accepted definition and is more clinical impression rather than a specific diagnosis. Blood pressure experience transient but substantial increase in patient experience transient but substantial increase in blood pressure. This is likely due to the sympathetic activation. BP usually falls without any intervention. Then these are actually the various types of the blood pressure variability. There may be bit-to-bit variability of blood pressure. There may be 24-hour blood pressure variability. There are day-to-day blood pressure variability. There are visit-to-visit blood pressure variability. So these are the different types of the blood pressure variability. And each and every blood pressure variability is important. Each and every blood pressure variability, if it is there in that condition, there will be endocardial damage will go on increasing. So pronounced fluctuation in blood pressure can occur over short and long-term observation periods. Finding difficulty.
Sir, you have to tell me next to proceed.
Next. So blood pressure variability and CV risk. We can easily see from this particular slide that if there is abnormal blood pressure variability in that condition, all-cause mortality, non-cardiovascular mortality, CV mortality, everything increases. Next. So this is the blood pressure variability and hazard ratio for stroke. With the mean systolic blood pressure or standard deviation of the systolic blood pressure or the coefficient variation of the systolic blood pressure, in everything we see that the stroke incidence goes on increasing. Next. So for that actual reason, though classical definition of the hypertension comes from the official blood pressure measurement, but there may be elevated, it may be elevated when the true blood pressure is normal, white coat effect. There may be normal when true blood pressure is elevated, masked effect. Office measurement may not reflect the diurnal variation. For that reason, 24-hour ambulatory blood pressure monitoring is a precise method to quantify the blood pressure level and diagnose hypertension. Next. So this is where the 24-hour blood pressure, 24-hour blood pressure measurement. Several studies has compared ambulatory blood pressure measurement with the intra-arterial blood pressure measurement and mercury column sphygmomanometer, and it has been found that the 24-hour blood pressure monitoring is very much important for us to diagnose a host of problem, as for example, the BP variability, circadian changes, the effect of environmental and emotional conditions of the blood pressure level, etc. Next. So this is one 24-hour blood pressure, ambulatory blood pressure monitor. Next. With the ambulatory blood pressure monitor, another very important thing is that the home blood pressure monitoring. This is a self-monitoring tool that can be incorporated into the care of the patient with hypertension and is recommended by major guidelines. A growing body of evidence supports the benefit of the patient home blood pressure monitoring compared with the office-based monitoring. These include improved control of blood pressure, diagnosis of hypertension, diagnosis of masked hypertension, and prediction of the cardiovascular risk. Next. So recommendation of the home blood pressure monitoring is there. A nice guideline is that generally at least twice blood pressure should be taken if home blood pressure monitoring is considered, at least once in the morning and once in the evening. Next. This is the Omron digital home monitor. Possibly it has it is generally recommended now by Indian Hypertension Society also. Next. So which one is better? Is home blood pressure equivalent to ambulatory blood pressure monitoring? So ambulatory blood pressure monitoring, home blood pressure monitoring, and clinical blood pressure monitoring or office blood pressure monitoring. Supervision is present in ambulatory blood pressure monitoring. Supervision is not present in home blood pressure monitoring, may be present, and clinical blood pressure monitoring supervision is there. BP pattern, day and night time pattern can be seen. Day and night time pattern, visit to visit pattern can be seen in ambulatory blood pressure monitoring. Only daytime changes can be seen in home blood pressure monitoring. In clinical blood pressure, in office blood pressure monitoring, only the office blood pressure, the patient visit blood pressure can be seen. The blood pressure variability 24-hour visit to visit blood pressure monitoring can be seen with the ambulatory blood pressure monitoring. Home blood pressure monitoring, day-to-day change you can see, and office blood pressure monitoring generally visit to visit change in the blood pressure we can see. Prediction of the outcome, best ambulatory blood pressure monitoring. Nighttime hypertension is very much crucial, and that can be diagnosed with the help of the ambulatory blood pressure monitoring. Superior to clinical blood pressure monitoring, home blood pressure monitoring. And though the home blood office blood pressure monitoring is the standard tool for diagnosis of hypertension, guidance to the treatment, guidance to the treatment most complete with 24-hour blood pressure monitoring. It is not actually complete, little limited with home blood pressure monitoring. Clinical blood pressure monitoring, it is limited and very much poor. Improving compliance may be very much helpful with ambulatory. Best evidence with home blood pressure monitoring and minor influence with office blood pressure monitoring. Next. These are the various guidelines of self-monitoring of the blood pressure is an important means of improving adherence. Next. These are Japanese Society of Hypertension recommendation of home blood pressure monitoring 2009. Next. This is how ambulatory blood pressure monitoring and the home blood pressure monitoring has given us the diagnosis and the definition of hypertension. With clinical blood pressure monitoring is generally 40 to 90 millimeter 90 millimeter of mercury. With ambulatory home blood pressure monitoring, it 135 to 85 millimeter of mercury should be considered as hypertension. Nighttime hypertension should be considered when the blood pressure is above 120 by 80 millimeter of mercury. Ambulatory blood pressure monitoring giving us this facility, and 24-hour blood pressure monitoring is giving us the facility that if it is more than 130 by 180 millimeter of mercury, according to the SEC and the AHA guideline, it should also be considered as hypertension. Next, where we are missing. Next, this is the out of clinic blood pressure with the masked hypertension, which is associated 70% increase in the cardiovascular risk, and white coat blood pressure, the clinical blood pressure, white coat hypertension. This is also associated with subsequent increase in the number of hypertensive patients and subsequent cardiovascular mortality. Next. This is the diapers and non-diapers. Generally less than 0%. If it is generally 10 to 20% diaping should be there with at the night. If it is less than 0%, it is reverse diaping, very bad actually. 0 to 10%, it is also non-diaping. It is also very bad. 10 to 20% if it is diaping, and more than 20% it is extreme diaping. Next. So this is the morning surge of the blood pressure. Early morning blood pressure more than 135 to 85 millimeter of mercury. Pattern of morning hypertension. It may be extension of the nocturnal hypertension. It may be the BP variability, and there may be morning surge also. All are associated with increased cardiovascular risk, occurrence of various events, occurrence of target organ damage. They generally do happen, particularly when the patient is under stress, when there is obstructive sleep apnea, patient had blinking in the night, and old age, and the drug did not cover the 24 hours interval. So next. So therapeutic consideration little bit. Next. So NICE is actually giving us the guideline that whatever the underlying mechanism, systolic blood pressure variability appears to be important. Independent.
You have to cut short because we are.
Yes, sir. I am going to the next last slide ultimately. So next. Yes, just before one. So the one before. So regarding treatment, actually, the amlodipine actually gives us the best facility of overcoming the blood pressure variability, and also the combination therapy, telmisartan and amlodipine. You can see from this slide actually. From this slide actually, this is the amlodipine arm, and this is the amlodipine and telmisartan arm. They actually give us the best control of blood pressure variability, daytime and nighttime, whatever it is. Next. So blood pressure variability control should be considered as a goal to guide choice of initial antihypertensive treatment. The mean blood pressure should be monitored as it is a potential marker for blood pressure variability. Calcium channel blockers are the antihypertensive class of choice for blood pressure variability control. Among calcium channel blocker, amlodipine as initial monotherapy has proven efficacy in reducing the blood pressure variability and mean blood pressure surge. Synergism between long-acting calcium channel blocker and ARB is definitely there. Next. Thank you very much, sir. Sir, time is very much less as a result of